talk. Dr. Atheek, you really need to get energetic because you've been plastered by Dr. Shirish here.
Can I start, ma'am?
Yes.
Sure.
So why I prefer to place CTR late? So I'm here to present two videos. This was a case where you can see about 2 to 3 clock hours of zonules not being present, and coloboma also, lens as well as iris coloboma. Rhexis in these cases is a little difficult, but doing it slowly, we can get over it. Doing a gentle, very slow hydrodissection and a delineation just for me to know where the nucleus edge is. And phaco in these cases, we have to be very cautious, be gentle, do whatever technique you feel is comfortable and you're happy with. And the parameters, these cases, you need to be slow. If we have high aspiration flow rate and vacuum, that itself can cause breakage of the anterior hyaloid. And removing the probe is something that is very crucial. We should not pull out the probe, inject visco and then pull it out. Cortex, we should ensure that we pull tangentially and not straight. That will ensure that the dialysis gets bigger. So in such scenarios, we'll be able to get away with it very comfortably. You can see here, everything is clearly visible. When the nucleus is present, we cannot be very sure where the CTR is going. You can see the capsular rim is clearly seen and cortex aspiration was actually a breeze. When the CTR is in, cortex aspiration really becomes very difficult. And you can see that the lens is again put into the capsular bag and the lens itself adds to support. So gently nudge the lens into the capsular bag. And this is case number 2, a mature cataract with about 2 to 3 clock hours of zonules missing. So that is clearly visible. Because this was a white cataract, we're trying to stain the anterior capsule for better visibility. And rhexis in this case was a real challenge. The nucleus itself was hypermature. And of course, with the dialysis, it is not that easy. But with re-injecting, you can actually do quite a good rhexis. I don't have access to femtosecond cataract here. So this is what I could do. And phaco, making a gentle nudge, creating a groove. And I'm here going ahead with the chop and splitting very gently. It is not advisable to split completely. Split, go down and split further. That will ensure that we don't traumatize the zonules still further. And now the second crack is made. As I said earlier, phaco parameters in these cases very important. You cannot play with usual high aspiration flow rate and vacuum. It has to be gentle. No harm in spending those extra few seconds in such cases for the benefit of the patient and to get good postoperative recovery. In this case, again, the space between the cortex and the nucleus is very less. So getting a CTR in early is actually difficult. Keep the probe in and then inject visco. Ensure that the chamber doesn't collapse and gently tease the cortex out. Again, for IA, we have to use slow aspiration flow rate and vacuum, reduce the bottle height and spend those extra few seconds so that we'll be able to do the case comfortably. IOL placement again is of paramount importance. You can see here, CTR implantation is very simple. The capsular margin is seen very clearly. You can be totally confident that the CTR is going exactly where you want. I'm more comfortable pushing it in this way. However, if we are more comfortable using the injector, we can do it that way. And the eyelets have to be positioned in such a way that we have adequate support. And the haptics are moved into position in such a way that the bag stabilizes better. Even better scenario could have been a 3-piece lens would have been even a better support. But then we went ahead and did a single-piece IOL implantation. So this was the end of surgery of both the cases. Well, Sirisha showed us studies which support CTR.
1 minute left.
We are showing cases where CTR placement late can be comfortable. Aiki Ahmed did a great trial where he says that placing CTR with the nucleus can cause more trauma to the bag and to the zonules, and it can cause damage to the zonules further. And the cortex can get trapped with the eyelet, which will make IA very difficult. In hard cases, as I said earlier, there is no space, so getting the CTR in is actually very difficult. And in soft cases, the epinucleus or the cortex can get trapped, and getting the cortex out becomes a real challenge. Main advantage of placing CTR late is we can visualize well and ensure that the CTR goes exactly where we want to do. Cortex aspiration becomes much more simpler. So CCC can be visualized much better and CTR can be placed easily. So I'm also telling the same concept, the same thing. Place CTR as soon as you need it, but as late as you want. Thank you, Chitra madam, team AIOS, and my mentor, Arul sir. Thank you. Thank you very much.
That was good, Atheek.